Welcome to today's episode, brought to you by the Women in Medicine Summit, a transformational CME conference happening September 13th to 14th at the Drake Hotel in Chicago. Engage in leadership programming, learn negotiation skills, receive on-site coaching and mentoring, and see who will win this year's I Stand With Her awards. This year, we're excited to offer unique programming that includes a special session on how using improv comedy can bring fun back into medicine. We also have financial sessions tailored to help you navigate the complexities of personal and professional finances. Discover ways to advance into leadership roles, combat burnout, and either reignite your love for your current role or find joy in a new career path. Don't forget our Friday evening gala, a highlight this year you definitely won't want to miss. Register now at womeninmedicinesummit.org and be part of the movement that is shaping the future of healthcare. Join us to network, learn, and celebrate the power of women in medicine.
Welcome to the Revitalizing Doctor podcast. We interview trailblazers in medicine that embody the Revitalize Women vision to empower women to innovate and influence medicine, to value authenticity, respect, and work-life harmony. We recognize the challenges in medicine, and we're committed to providing coaching-informed strategies to help you go from surviving to thriving. I am thrilled today to have Dr. Mary Mulcare, who serves as Summus Chief Medical Officer and oversees all clinical aspects of Summus operations. Mary also serves as Clinical Assistant Professor of Emergency Medicine at New York Presbyterian, Weil Cornell Medicine, and has held several leadership roles at Weil Cornell, including Director of Undergraduate Medical Education in the Department of Emergency Medicine and Assistant Director of the Margaret and Ian Smith Clinical Skills Center. She brings deep medical experience and a commitment to patient and physician education. She continues to make significant academic contributions to the fields of medical education and geriatric emergency medicine. She completed her undergraduate education at Princeton University and obtained her medical degree from Columbia University College of Physicians and Surgeons, graduating with honors from the AOA Medical Honor Society and the Gold Humanism Society. She served as chief resident of the Emergency Medicine Residency Program at New York Presbyterian Hospital and completed a fellowship in geriatric emergency medicine at Weil Cornell Medical Center. Wow, that is quite the bio. Welcome to the podcast, Mary.
Great. Thank you so much for having me.
So the way we like to start every podcast is, why did you go into medicine? You've had a really interesting path since being in medicine, but going back to, I don't know, however old you were when you started this crazy journey, what was the initial drive?
Always a good question. Always a good place to start and a good question to open with. And so I think, the simple answer is my dad was a doctor, and so I grew up with it. I saw how much he loved what he did and the impact he had on people. Just watching him over the years, it was just a testament to the profession overall. As I got to college, did the typical pre-medical curriculum, tried to round out my education with other things thrown in the mix. And by the time I got to the end of college, I thought, well, am I 100% sure? This is a big commitment if I'm not 100% sure. So I spent 2 years in consulting. So I sort of took a little side path for a few years and actually did healthcare consulting. But I found with every project I was on at all these different great hospitals out there, great entities I was working with, but I was sitting in the business suit across the table from the people in white coats. And I found very quickly I really wanted to be that person in the white coat, really changing care and affecting people over time and really helping the healthcare system move forward rather than in the suit on the side of the aisle that I was sitting on. So with that, I went back to med school.
Wow, that's really, really interesting that you had that early foray in business. What was your undergrad in?
So majored in biology, as is probably consistent with a lot of physicians, and had a minor in American studies. But I really spent most of my undergraduate just trying to dabble in as many different things as I possibly could. Ironically, econ was my least strong of any of my coursework I did. I wasn't going to be in the finance sector per se.
So now let's leap way far ahead, I think, in the story. Where does Summus enter? And for our listeners, what is Summus?
Yeah, so Summus is a virtual specialty care platform. And so what does that mean? The way that I can describe virtual specialty care is by comparing it to more traditional telemedicine, right? Because telemedicine is something that we're all very comfortable with. Telemedicine is you schedule your video appointment, you get your video set up, get your audio set up, pop up, there's your physician, whether it's an on-demand urgent care visit, whether it's a visit with your PCP, a specialist, post-op visit, whatever have you. But it's a fairly quick visit that has a pretty distinct purpose most of the time, pretty transactional in nature, quite frankly, in terms of whatever the mission is of the visit. And that's that. Virtual specialty care is really aimed at a more longitudinal relationship with our members and our patients. And it's really about helping people understand their healthcare journey and helping them feel empowered to make better healthcare decisions. And there are a lot of layers to that, which I think we'll probably chat about a little bit more here. But the way that, Summus has built it out is such that, our mission is really to restore the human connection in medicine and to bring back some of that trust to the healthcare environment while also enabling people to get on the right journey much more quickly and have, with speed and access, can get to high quality physicians in very short order. The one-liner of how I describe Summus, is that we're essentially scaling what I do for friends and family on a daily basis, what you do for friends and family on a daily basis, what all of us do who are physicians for our friends and family on a daily basis.
So I love what I'm hearing so far. And I want to circle back to this idea of trust in medicine, but I want to make it a little bit more granular. I went on the Summus website and of course I'm listening to the video and I'm like, wow, this sounds amazing. Like this is what I want healthcare to be from the physician side and the patient side. So how does somebody become a Summus patient or client?
So there are a few ways. We do have a consumer track where individuals can come in and purchase a membership to all of our services. The most common way is through employers. So we work directly with a lot of employers who are largely self-insured. They layer us as a benefit on top of their traditional medical benefits. And so the employer pays for our services for all of their employees. And then their employees can come into our ecosystem literally with any healthcare question they have across the spectrum of healthcare. And that's one of the things that's made us successful to date is that it's literally one open text box that says, how can I help you? And they can ask any question, whether it's, 3 years ago, where do I find a COVID test? All the way through to, I've just been diagnosed with X, Y, or Z esoteric cancer diagnosis. No one where I live knows what to do about it. Help. And we can help walk them through the diagnosis, understanding where they've come, where they're headed, get them set up with a specialist or subspecialist as the case may be that can directly address their diagnosis, their questions, and help them figure out what their options are going forward.
So looking at your website, I saw some of the top diagnoses that somebody might reach out for is, let's be honest, you and I are both emergency medicine physicians. There are diagnoses that make me cringe, like fibromyalgia, because I don't know how to address that in the emergency department. I don't have any tools. Nobody on my team is supporting me to try to help that patient. So is that an example of a diagnosis that somebody could say, help me with? I'm struggling. I've been to my primary. I've been to a rheumatologist. I've gone to physical therapy and everything that's happening is making me worse.
Mm-hmm. Yeah, absolutely. Absolutely. Now, the next natural question is how? How do we help with that? So the fulcrum of our model is what we call our Summus MDs. So anybody that comes in with any clinical question, they first get sent to one of our Summus MDs to talk to. And the Summus MDs are a combination of, internal medicine, primary care, emergency medicine, geriatricians, pediatricians. Now, in all fairness, the fibromyalgia question is probably not going to come to an EM person. We will probably triage that to one of our internists or primary care docs. But the premise of this initial conversation is really education and guidance and helping somebody understand, all the visits they've had, why have they been told they have fibromyalgia? Where is it coming from? Understanding all the different pieces of the story that fit together, trying to help somebody, sort of look introspectively as to what they're doing, what steps they've taken, what medications they're taking, understanding what medications are actually supposed to do for them. I think one of the places our healthcare system falls down a lot is that the physicians who are treating patients for whatever the disease process is, they run out of time in the clinic visit to describe what the medication specifically is, what it's supposed to do, what the side effects are to expect from it, how to handle those side effects, and what next steps to take. So we find that our Summus MDs just in the 30 minutes, they spend, on average 30 minutes with a patient, just in that 30 minutes of just educating people, a lot of problems are solved and people can stop bouncing around the healthcare system because they finally understand why they've been told what they've been told and why their physicians are trying things in a stepwise fashion that they are trying and how they should best communicate with their doctor, what they should tell their doctor about different side effects, different symptoms, like what's helping, what's not helping, and trying to get them on that longitudinal path, rather than just shotgunning everywhere, trying to get an answer.
When I was thinking about this, I was curious about how does Summus interact with medical records? Like, is there any interface with any EMRs, or is it incumbent on the patient to upload if they so happen to even want a Summus physician to review what's been going on?
Yep. So a few ways that we go about that. And you're actually trying to touch on sort of a different arm of what we do. But so we do medical record curation, both collection and curation for people, depending on what's needed for a specific interaction. How we do that depends. It's easiest for us if the patient has access to their records and can upload it directly to our platform. That's usually the most streamlined. We do have medical records specialists that can go out there and get records on behalf of a patient. We have all the release forms and whatnot we can do to make that happen. We do integrate with some EMRs, but that's for sort of a separate stream of business. So we also do a lot of work in the P2P space. So peer-to-peer, physician to physician, whatever you'd like that P to stand for, depending on who's on either side of the equation. But we do different things in the P2P space, which we can also talk about. And the EMR integration on that side is also for communication purposes with different health systems and to help show, the interactions we've had and what's happening, as well as to push records back to systems. If patients are, for example, getting a remote written second opinion done and they want to convert their care to that institution who did their second opinion, we can push records back into that institution.
That's fascinating. There's just so many threads, but the next one I want to spend a little bit of time on is this idea of time and trust in medicine. And my theory on part of what went sideways during COVID, which there were a lot of things, is it was a prime example of how patients don't trust us anymore. And I think back to my experience growing up in a small town in which there were only a handful of physicians. We knew their names. They came to the football games on Friday nights. And while I always felt like the head doc in my town was really busy, I also felt like he knew us. Like he knew our community. He knew my family. And there was a trust embedded in that. And since I've lived in San Diego, I've never had the same primary care physician for more than a couple of years. They usually quit, honestly. I've watched. They just kind of move off into the ether. Sometimes I see them pop up on LinkedIn as a coach or something else, weirdly enough. And so I was really frustrated with patients coming to the emergency department that wouldn't take their COVID vaccine, wouldn't listen to me. But on the flip side, why would they listen to me? They don't know me. I haven't established any rapport or trust with them. And unfortunately, they're consuming social media and Instagram. And maybe that holistic practitioner seems a lot more personable and is making time for them. So what's your reaction to that analysis that I've had on the crux to the problem in healthcare?
Yeah, no, you sort of hit on it. I think there are a few different levers to this, right? There's the primary care physicians and the general internists that I think in general haven't been treated very well by our healthcare system. And so they're tired. They're burned out. They don't really want to do it anymore. I don't blame them. Several of them do come work for Summus and love it, and just because I think a lot of what Summus does for the physician, it's sort of a physician wellness play, if you will. A lot of what Summus does for physicians is remind them why they went to med school in the first place and sort of give them that space to just talk to people and help people understand healthcare and understand their journey. It's partly the physician physicians are tired and burned out. And so that can make interactions more short and snappy than anybody wants them to be, physicians or patients, anybody. And I think patients are often left, the time constraints, patients just don't understand. No one's really sat down and talked them through all their options and why a decision is specific to them, not just good for the population overall. People can understand the basic concepts of population health and why vaccinations are important for the overall group. But then when it really comes down to getting a needle in the arm, it's about them. And people really want that individualized, personalized attention as to why they should get the shot in the arm specifically for them. And even them and their immediate family. It doesn't even have to be just that person. And that's part of what we do, just really personalizing medicine down to the individual.
I want to also ask it in a little bit of a different way because I've done telemedicine. And one of the really interesting things about telemedicine at the company I work per diem for is it is very clear to the clinician and the patient how long the interaction is. There's a timer up, and I've watched patients start to wrap up because they see that timer kind of self-contained, like, okay, I wanted that prescription. Yep, I'm good. Thanks. And it was really kind of transformational for me in a good way because a lot of interactions we have in the world involve clear communication about time. I go to my therapist. I'm going to go later today. It's an hour-long visit and it's very clear. And it really doesn't matter what I say at the end of that hour. It's going to be like, wow, okay, we'll need to come back to that, but I'll see you at our next session. There's a clear boundary. And I kind of feel like healthcare, we do this really weird thing where most patients actually don't know how long the encounter is in a lot of settings. So with Summus, is it clear when a patient signs in or what you communicate to your providers or clinicians about like, hey, this is how long?
So it's the half-hour appointment block that's scheduled specifically for the provider, for the patient. So it's clear in the sense that on their calendar, that's what shows up. We do not have a timer running. Yeah, that's sort of the antithesis of what we're trying to do on our side. I can see why for some, but I think that's exactly why like the traditional telemedicine visit is very transactional. Like I want my Z-Pack, I want my med refill, I want whatever the patient's calling that they want, as long as you're willing to give it to them, and they see the clock tick down, great, you're out the door, right? But patients come into us, it's more complicated. And a lot of times they come into us not really knowing what they want, which is part of the lesion with the healthcare system, right? Like healthcare is complicated. There's a reason we go to med school for 4 years, train for another 4 years, plus fellowship, plus whatever else we do, just to get the basic understanding in one specific specialty, right? And then years of attendinghood is really where you learn more and more and you build that set of knowledge. Like we can't expect people who haven't been through medical school, haven't been through all this to fully understand. So we're here to help bridge that gap. We found it's interesting when Summus initially started 7 years ago. Initially, the premise was sort of, fast access to specialty care. So everybody that came in, we thought, okay, well, this person definitely has to go to an expert consultation. And we teed up the cases, to get these expert medical opinions. But then over time with our Summus MDs, we found that our Summus MDs were actually solving 80% of the problems. And our patients come into our Summus MDs and the case can go one of three directions. The Summus MD solves the issue. The patient just needed that education and guidance and needed to understand what was next, why they'd been told what they'd been told, and how to approach their doctor, and what succinct questions to ask specifically, to your timer point, going forward. This interaction ends there. Some cases come in and the Summus MD says, you need to see a specialist in person. This isn't a virtual issue. This isn't something that we can handle in this medium, right? Which is fair. That boots on the ground medicine shouldn't go anywhere. And it still has a very valuable role in the overall healthcare system. So if that's what happens, then we help provide the member with a curated list of physicians that fit, what specialty they need, location, any DIB criteria that exists for the patient. We try and help curate a list in network to reduce costs for them so that they know where to go. Or third, we can escalate to an expert opinion, right? And if the case really does need to go to an expert opinion, think, a lot of the oncology cases often do surgery avoidance questions. Do I actually need that spine surgery? Yes or no? A lot of times, those are the types of things that will get escalated up. Very rare diagnoses, that stuff gets escalated. Or people that have, seen 3 different ENTs about whether or not their child needs their adenoids out. Like, a lot of times we can just talk them through what each one told them and how to make a decision. Sometimes we need to bring in a tiebreaker, it depends. But I think my point being, though, when we started the business 7 years ago, sort of 100% of stuff went through to specialists, subspecialists. Now, 7 years later, only 20% does. That's just because our Summus MDs are amazing and they can handle it. And when you give primary care, EM docs, people that have seen a lot and know a lot, just with space just to talk to people, that's your job. We don't prescribe. We're not here to primarily diagnose you. We're not here to place orders on you. Our communication, our documentation is specifically for communication purposes. We're not billing insurers. So we're not checking off 9 review of systems just to make sure that we, hit a certain level of billing and coding. It's literally essentially just documenting your E&M for the point of communicating to the patient take home points and communicating to whomever they talk to next so that everybody knows what happened previously.
So that brings up my next question, because I had a pretty negative interaction with a patient a few years ago at a ER and I don't work at anymore that had a high percentage of concierge clients. And he literally said to me, I don't want to talk to you. You can call my concierge doctor. And I was just like, okay, this is some weird dynamics here. I have no problem calling somebody's primary doctor, but I still think there's value in me having this face-to-face conversation and exam. Will Summus interact? If the patient's like, you know what? I love you so much, Dr. Mulcare. I want you to call my rheumatologist and explain this to them.
So primary care docs, your concierge med, whomever, they're welcome to come join the consultation if they would like. It depends you have to be very careful as to what line of business we're talking about. So in the education and guidance world, we're not going to do physician to physician consultation without the patient being involved. The patient can be there and that's going to remain in the education and guidance world. Other streams of business, though, when you're talking about P2P directly, that is something that we can engage with. You have to be very careful, though, when you're involving, I'm going to get sort of into the weeds on this, but you have to just set up very clear expectations on what the purpose of the consultation is. And we're very careful with our physicians in our education and guidance business. They're not directing care. So we have to put very tight parameters around what we can do.
So if we could just make a more granular example. So let's say I'm a patient that's had some issues with abdominal pain. I've seen 10 different specialists, and based on the conversation, I don't know, maybe the Summus doctors recommended a camera pill. And the patient says, my gastroenterologist is blowing me off. I want you to tell them. Is there a product line that Summus would interact with that doctor, or would it only be if the patient was in that consultation room with the GI, their own GI, and got permission from that gastroenterologist that, hey, I'm working with this company and I'd like them to talk to you directly? How are those situations navigated?
So I think the way that situation typically comes up is, in our, right? So you can see that in our employer business where a patient comes to us and says, my doctor, sometimes it does happen where they say, my doctor won't listen to you, whatever. And the answer from the Summus MDs on that is well, why won't your doctor listen to you? And if you're really having that much friction with your doctor, let me help you find a different doctor.
I love that.
Because getting me on the phone directly with your GI specialist isn't, the situation is deeper. We're in a different place than just talking about swallowing a pill with a camera in it to trace your intestinal tract. If the patient says to us, sometimes the patient will say to us, how am I going to remember to tell my doctor that? That's where we have our consultation note. We can write down one of the things that you should potentially talk to your doctor about is whether or not X, Y, and Z capsule study is appropriate for you, right? And then the patient can print that out and take it to their doctor and ask about it. But it's ultimately up to the patient's physician, their GI doc, their primary care doc, whomever it is, to direct the care. We're here to help augment that process. And our job is really to make sure the patient understands all their options and understands the questions to ask. But to your initial scenario, if the patient comes in saying, my doctor's not going to listen to me, like I want you to talk to them, then it's let's back up, because that relationship isn't copacetic to begin with.
I really like that. And I've gotten to that point with patients in the emergency department that they're complaining to me about their primary care and asking me to try to fill a gap that I can't fill. And I say, well, we need to take a step back here. There are just times that the relationship's just not working. I'm not throwing another doctor under a bus, but there's a myriad of different reasons why that relationship may not be working. And I get it. It's complicated. It's hard finding a new doctor, especially right now. I think I'd be interested in what you're seeing. Summus has a pretty large reach, right? It's more than just the East Coast. You're at least across the United States, right?
Correct. And we power second opinions in the international space as well.
What are you seeing with trying to get patients quality primary care? And to that note, this is kind of a two-part question. Are you able to still get them good primary care? And what's your approach to a patient I see very commonly in the emergency department? They're very sick. They have 10 different chronic medical problems. And they say, well, my nephrologist is my primary care, or my cardiologist. Those are the two specialties I probably see the most, with somebody saying, well, this is my primary care. And I'm looking at it and I'm like, well, they're actually not.
Right. Well, I think this gets to a much bigger problem in our healthcare system where, I think the healthcare system was designed with the concept of a primary care physician being the quarterback. But the reality is the primary care physicians haven't been treated that way over the years, and the primary care physicians have sort of been backed into this corner of effectively being admin, just getting a couple labs and then firing off consults to different specialists, and no one ever reports back to them. And therefore, they're kind of at this complete loss. So I'm not sure, the poor primary care docs haven't exactly been handed a fair system to go with. And I do hope that's one of the areas where with Summus, we can help some of these value-based primary care groups that are starting up, help provide them a specialist overlay, in the P2P space to really allow the primary care docs to be that quarterback and to sort of bring our system back to the original inception of what it was designed to be. TBD if that works out, but I really hope so. But to your question about quality primary care, it's hard. There are not a lot of true primary care doctors that exist. It's hard for them to make a living in the way that things are currently structured, and it's not always as fulfilling as was once imagined. That being said, we do our very best, and we've created a network out there of people that we know and can tap into. We've got a great member experience team who spends a lot of time, researching all the options out there and all over the country. We have our ways of honing in on who's where, what the options are, trying not, sort of build an overall experience score on them. The conversation about how you measure quality of a physician is a whole different, subset of conversation that we can get into. But that's something that I think people have been really wrestling with. And I have a hard time with a lot of these companies out there that claim that they do physician quality scores, because it's silly. Like when you actually look behind the curtain as to how they're doing it all based on big data, claims databases, looking at complication rates, looking at, overall procedure volumes. And then I ask them, I'm like, well, high quality hamburger. McDonald's makes the most hamburgers in the country. Is that where you would go for your quality hamburger? Right. And then they just sort of look at me. And then the hard thing is the physicians that take on higher risk groups are more likely to have complications. But that doesn't mean that they're any worse. Quite frankly, they're better half the time because they're dealing with very complicated people. But based on a claims database,
they
have a lot more complications.
Right.
Right. So their rankings are going to go down. Then they're trying to look at, scraping websites for reviews, your Yelp reviews, your, whatever reviews exist, right? Which we all know, but who writes reviews? For the most part, you're dealing with extremes. So it's really, these quality metrics, it's a world that's really, really hard. But we're focused on it at Summus. We're trying to come up with our answer. I think we have our own internal quality metrics, and a lot of it's human-based. I think this also gets to the conversation of AI, and where AI fits in this world and where it doesn't fit in this world. And I think there's a lot in the quality sector that's very human oriented. And I don't know how we're going to get around that with AI. But from a quality perspective, one physician is perfect and considered high quality by one person, and then not at all by the next person. That's because physicians are humans,
Right.
right? And they have certain qualities that speak to some people and other qualities that don't speak to other people. And so I think each case has to be taken individually and a personalized choice has to be made.
Thank you for listening to The Revitalizing Doctor. We have an exclusive offer for our listeners. Get 20% off your Epocrates subscription. To redeem, go to the website epocrates.com and log into your account. Click on the payment and subscription link to redeem the discount using code REVDOC20. That's all caps REVDOC20. This offer is good for new subscribers and cannot be applied to active Epocrates Plus subscriptions. Thank you for listening. Now back to the show.
Stay tuned. We'll be right back. Are you a physician mom with school-aged children feeling utterly exhausted? My friend Dr. Sheeta Shaffi invites you to take a little time this summer to join her in a small, intimate group for meaningful conversations. Dr. Shaffi is an emergency physician, coach, and mom to 8-year-old twins. She understands firsthand what you're going through. This isn't a pizza party or a yoga class. You'll meet for 2 one-hour sessions twice a month starting in July to help you move out of exhaustion, let go of mom guilt, and live a life you're not only proud of, but can truly enjoy. Connect with her on LinkedIn or Instagram at Sheeta Shaffi to learn more. Sheeta is spelled Shideh, and Shaffi is spelled Shafie. You can also check the show notes for a link so you can connect with her there as well. So I want to pivot a little bit and spend some time about how your career led you to Summus. So part of what we do here at the Revitalizing Doctor is trying to provide a roadmap to a lot of physicians that we've actually hit on today, the physicians that are feeling very frustrated and that this wasn't what they signed up for. And maybe, I say in a lot of episodes, clenching the steering wheel as they're listening to this, saying, I want to be doing something more exciting and that has a bigger reach, like Dr. Mulcare.
Yeah. So Rain, I'm sorry, I sort of glossed over this the first time you asked the question, but how to get to Summus in the first place? I think so. The short answer is one of my co-chief residents is one of the co-founders of Summus. So I'd been following it, on night shifts from its inception early on. She, along with 2 other co-founders, had started it. She was the clinical arm, along with our current CEO, who is still managing the business. And then actually her husband, who is a surgeon, gone into the venture capital world, who did a lot of fundraising. Over the years, Jen's her name, she had sort of veered off actually into industry to do other things. And so I sort of took over for her at Summus as the medical director and just, as a startup. So as it was growing, I did, was one of the first Summus MDs that did consults for them. I did expert consults in the geriatric realm, since geriatric emergency medicine is my subspecialty. And I really enjoyed it. For me, it was a nice balance between emergency medicine grind. And then I got to do this where I literally did what I do for my friends and family, but actually got paid for it. Kind of nice, and enjoyed advising the company as it grew. I didn't expect I would ever be in this role. I didn't know where the company would go or what would happen with it, but it was fun, interesting, different from what I did on a daily basis. And then obviously COVID hit and completely flipped virtual care upside down. I had a wonderful hybrid career at Cornell. I really enjoyed Cornell, where I was half clinical, half education, doing a lot of different teaching. I had the geriatric research stuff on the side, and we had a really great geriatric EM research group. We were doing a lot of work in elder abuse, which isn't the most exciting side of emergency medicine, but super important. And I built a really nice hybrid career. But with COVID, my family moved out to Connecticut. I had 2 little kids. There was a combination of work-life balance that hit. And then I just saw this need, as you all know, I don't need to, talk to this group, but, patient after patient with COVID gets exhausting. And then I found with Summus, I could go on and do webinars, educating people, at all these different employers about where was COVID, what was happening with it, who should get tested, who shouldn't get tested. At that point, we were still trying to spare tests, right? So talking people through it, talking people through the symptoms, like, yes, if you lose your taste, that's actually a thing, right? Which for a while, we had no idea, GI symptoms. Oh, wow, that was actually a thing. So when you think back about how much we were learning and how much it was changing, with my role with Summus, I had a chance to sort of reach more people and actually, distill what the evidence that we had and the learnings that we had so that more people could understand what was happening with it. A year and a half into COVID, the company, had a capital raise, did well, wanted to expand their C-suite, and asked if I was interested. I didn't realize they asked at first. When they asked who they should have for their CMO, I started rattling off people I thought would be great at the job. And then they said, oh, wait, so you don't want it. I'm like, oh, wait a second. Didn't even occur to me. And then I got in my car and drove 2 hours to shift. And then I called them back and was like, hey, let's talk about this when I get off my next overnight. I joined July of 2021, full time with Summus, which has been amazing. Huge learning curve. I've learned a ton, but I feel so fortunate to be a part of a company that's really, sort of put physicians at the center of how we operate, which is different from a lot of healthcare, and it really is focused on like, how do we really make this a great physician experience? Because ultimately a good experience for the physician translates to a good encounter with a patient, translates to the patient understanding what they need to do and walking away more empowered in their healthcare journey and hopefully having more trust in our healthcare system. And so from our perspective, that starts with the physician, which is just a different model, I think, from what exists in a lot of healthcare. So I'm lucky. We've got an amazing team and we're growing and doing a lot of different things. And so it's been a fun ride. But I think my main take home point for people on this would be, I got here because I said yes to a lot of things, dabbled places. I had no idea where it was going, but eventually I lucked out, right place, right time, and took advantage of an opportunity that was it was a little scary to jump from academia to this. And I'm lucky I still get to teach at Cornell. I'm still on voluntary faculty at Cornell. I still get to be involved there. So I'm lucky I still get to have a little bit of that hybrid life, but it's been a good move.
What do you think the biggest thing you've done in the last couple of years that propelled you to really be able to flourish in this role as CMO, to move into the C-suite?
I've had a lot of leadership opportunities that I took advantage of. I think especially for anybody listening in academia, you realize there are a lot of roles that come up that you get paid zero to do, and there's a lot of time spent for no remuneration on the financial side. But I think only because if you view it in the right lens as to your own like personal growth, it can have a really big impact. So I think over the years, I took on a lot of leadership roles, a lot of mentorship roles, but it really allowed me to experience things outside of just clinical medicine and understand how to run a team, I was one of the assistant program directors for the residency for 7 years, like talk about a thankless job. But I learned a lot. I learned a lot about how to manage 40 additional children, and how to get people from point A to point B in their career, and then ongoing mentorship. I learned a lot when I moved more into the medical school and running a clinical skills center with people outside my specialty, and what do all different specialties need to know, and how do you take more novice learners and get them from point A to point B. So I think just a breadth of experiences. I think the other thing for my current job, though, is I was always, sort of going back to my 2 years in the consulting sector, I was always interested in sort of the business side of healthcare and how it worked. So I think I always the billing and coding discussions, I know we sort of laugh at them and joke about them, but I actually paid attention. Like I was actually kind of curious, like, well, how does it work? And how does it work with payers? And how does the system all fit together? That stuff I always found really interesting. And so just asked a lot of questions about thorns that are in our side all the time in terms of, how to run an ED, how to run a hospital. But that was stuff that always really interested me. And so I just sort of paid attention.
And looking back at your bio, correct me if I'm wrong, you do not have an MBA.
I don't. And that's always been it. So I help.
But I love that. Our listeners need to hear that right now, because the number of people I get that tell me I can't become X until I get my MBA. Can you please put that to bed?
Nope. You don't need an MBA. You don't. And I get asked this actually all the time because I help run the healthcare leadership and management program at Cornell. And the other people that all run it are MD MBAs. But the first thing I'll say to people is I do not have an MBA. Have I thought about it? Sure. But I don't know. I sort of have the perspective of a lot of what the value of an MBA is networking and meeting people. And I'm not sure I need to pay $180,000 or whatever it is a year to network and meet people. I mean, medicine is a huge network in and of itself. I think really what you need is the experience. You need to say, yes to certain projects, yes to leadership roles. You need to sort of figure out where you can get the on-site learning and do that, and where you can get the mentorship. But I think whether or not you're sitting in classes to specifically get an MBA behind your name, like that doesn't need to happen.
So on that note, we've had quite a run of tech people on the podcast, which has been super awesome. What is a conference that you would recommend people go to that like, oh, this is where you start to meet people at Summus and Hippocrates and all these other where med and tech interface?
I think my favorite conference is the ATA, the American Telemedicine Association. I know I spent a lot of time talking about how virtual specialty care is different from telemedicine, but we're all in this, we're all in this virtual world. I think ATA is a really nice hybrid between academia and industry. And it allows a meeting of the minds there for people to really figure out what's going to help healthcare in general and what's going to move the needle. And that conference is full of everybody from, again, from academicians to people in industry to finance folks, to investors to payers. It really runs the gamut. And it's a very nice collaboration at the conference, I think. So that would be my top recommendation, I think.
I love it. All right, we're getting close to the end. Is there anything I didn't ask you or any tip you'd like to share with our audience?
I guess the one thing I would say is don't be afraid to make the move that's going to create a little bit more work-life balance for you. I think people get so focused in sort of the path that they've set in medicine. There are a lot of options out there, and there are a lot of ways to use your MD and to use your brain and all the education and guidance in fulfilling ways. And that's not to jump ship from what you're currently doing. It's just a matter of finding the right balance for you. And also not being scared to take on some of those other opportunities that might not have been on a traditional medicine path that you thought you were going to follow. So the world's wide open there. And I think the nicest thing about I'm just coming off April, which is conference season. I've been on the road the last 4 out of 5 weeks at different conferences. But one of the big ones I was at called Health Evolution, which is sort of the thought leadership group around healthcare. It's one of the main takeaways from it was we need physicians in leadership positions if we're going to get healthcare to where it needs to be, which is an amazing takeaway point as a physician. And that it's being recognized that physician leaders are crucial because we understand how the system actually functions, on the front lines. And you need that understanding in order to be able to make sustainable changes that are actually going to influence patient outcomes and improve the overall health of our society, which is the ultimate goal, and then help to rein in costs. And you can't rein in costs if you're making people sicker. It's not going to work.
Well, that's very exciting to me to hear that leaders across the industry and beyond are starting to hear the same drumbeat that I think a lot of us have been beating for a long time. So would you say that your outlook is, dare say, optimistic about the future of healthcare?
I think so. We've got a chance to change it. And I think we're hitting a point where we have to change it. So it's just a question of how. And a lot of the big groups and the big operators are willing to take chances and do different things. I mean, we're seeing it at Summus all the time. People that I never thought would be interested in us are coming up to us and saying, hey, we need to be innovative. Give us some ideas. And I can sit down and talk them through where we're going, what I think might help their system. And they say, great, here's the contract. Like, oh, well, wait a second, but I think people are willing to change and people recognize now that we've got to make some moves. I think we're in a good place. And I think physicians specifically are in a good place to help it happen and have a voice at the table as to how we want it to happen in order to best, promote people's healthcare.
I love it. I think we just found the name of this episode. Make some moves. Make some moves in your own career, and the system's ready to make some moves. So, how can our listeners connect with you and Summus?
So I'm happy to hear from anybody. So our website is www.summusglobal.com. It's SUMMUS global.com. And on there are links to, get more information, reach out, and any physicians. If you go into the physician part of the website and request more information, you'll actually basically come to me directly. But you can also, any physicians are welcome to reach out to me. My email is mulcare@summusglobal.com. And LinkedIn, feel free to reach out on LinkedIn too. That's always easy.
One parting question. Do you have any emergency medicine groups that are working with Summus right now?
Groups, if you're thinking like the bigger sort of private groups, no. Do I have a lot of individual emergency physicians? Yes.
I think this is really something, maybe we can have you back on for part 2 to dig into that more, because I get so frustrated on an average shift with somebody that I don't understand their insurance and the intricacies of how to get them. And I don't have the time and I'm not resourced to do what Summus is doing. So I think there's a real opportunity here to improve the working lives of emergency physicians and patients. Again, we say that at Revitalize, and I love to hear you say it, that what's good for physicians is good for patients. And if we start there and we keep looking for solutions, it's going to get better. All right, more to follow. So I really hope that a lot of our physicians and leaders, and frankly, a few patients listening, will look into Summus and start asking, so is this something a physician, any listener could go to their HR department and say, hey, I just heard this podcast and I want Summus here?
Yep. And then we're happy to get you what you need to make it happen.
All right. Well, Mary, this has been one of the most interesting conversations, and somebody who gets to podcast and have interesting conversations regularly, this has activated my brain in a way that I'm really excited about.
Glad to be of help.
Thanks for listening to The Revitalizing Doctor, a project of Revitalize Women Physician Circle. Our mission is to connect women physicians and allies through innovative, value-based coaching methods that align trust, support, accountability, and skill development to ignite the courage and clarity necessary to take bold actions, create change, and thrive. If you're interested in working with us, check out our website at peoplealwayshcc.com/revitalize or email us at revitalizem.info@gmail.com. This podcast represents the views of our host and guest. It does not reflect the views of any institution we work for or with.
Hi, it's Dr. Risa E. Lewis, dropping in to tell you about a book that Dr. Adara Landry and I wrote. It's called Microskills, Small Actions, Big Impact. It's a business self-help book coming in 2024 by HarperCollins. Pre-order now, Microskills, Small Actions, Big Impact, wherever you buy your books.